this video we are going to start our discussion on induction of labor. So what is induction of labor? First let us start with the introduction. So actually induction means we are going to start the labor. The labor is not going on in the mother, so now we are going to start it. It is actually an initiation process of labor, especially in a quiescent uterus. So uterus is quiescent, it is still not responding, it's not ready for the labor, so we ourselves are initiating the labor. Okay, and what is augmentation? Augmentation means it is accelerating the process of labor. So okay, labor has started, but now we need to accelerate it, so that process is called augmentation. And in a uterus which is already contracting uterus, you will do augmentation. Induction is, it is like an initiation. Okay, so what is spontaneous labor? Uterus by itself initiates the process of labor, that is a normal spontaneous labor. So these are the three things which you need to know: induction of labor, augmentation of labor, and spontaneous labor. So spontaneous labor means uterus itself is spontaneously contracting. Augmentation means you are increasing what are the contraction is there, you are increasing that contractions. Induction means there are no contractions in the uterus, so now you are introducing the contractions. So these three terms should be clear. Now coming to indications for induction of labor. So what are the indications for induction of labor? So for example, you say pregnancy which is induced due to hypertension, that is PIH. In the case of PIH with mild preeclampsia, you will induce labor at 37 weeks, because in this patient they are already having hypertension, so there you are going to induce the labor by 37 weeks. And in the case of severe preeclampsia, you will, I'm keeping here S means severe. In the case of severe preeclampsia, you will induce labor at 34 weeks only, because already it is severe condition, so let us do it in 34 weeks itself. But in the case of normal PIH, in the case of normal mild preeclampsia, you will do 37 weeks. And in the case of HELP syndrome or eclampsia, in the case of eclampsia or HELP syndrome, you will do it immediately, because HELP syndrome is a very critical condition, and even the eclampsia, right? So that's why we will do it immediately. And even coming to premature rupture of membranes, in that also membranes rupture it after 37 weeks, but before the labor begins, so induce labor immediately. So what they're saying, membranes are rupturing after 37 weeks, but the labor begins before only. So here also you will induce the labor immediately. Okay, IMM means immediately. And next coming to preterm premature rupture of membranes, that is PPROM. So here what you do is the membrane is ruptured before 37 weeks, so induce the labor at 34 weeks. So here we induce the labor at 34 weeks. Membranes are ruptured at 37 weeks. So preterm premature rupture of membrane means membrane is ruptured before 37 weeks, but we will induce the labor at 34 weeks. Okay. Next coming to post-term labor. Post-term labor, here you induce the labor immediately here also, because already it is so late. Post-term means it is greater than 42 weeks. Okay, so coming to Abruptio Placenta means the placenta is already abrupted, so here also immediately. And in the case of chorioamniot, it is already amniotic fluid got inflammation, so here also immediately. So all the severe conditions immediately. Okay, coming to oligohydramines, there is low amino fluid, so you will induce at 36 weeks. And when your conditions like oligohydramines with intrauterine growth restriction, both conditions, so at 34 weeks. And in the case of gestational diabetes, the mother is having diabetes at the time of gestation, right? So more than or equal to, greater than or equal to 39 weeks you will do. And in the case of RH isoimmunization, if there is severe anemia, if you do peak systolic volume in middle cerebral artery, if it is greater than 1.5, then you need to induce labor at 34 weeks. Okay, in the case of peak systolic velocity less than 1.5 or antibody titer is less than 1:16, I think you need to induce at 37 weeks here. So actually this chart is very important, you just need to mug up this at what time, what you need to do. Okay, so coming to indirect Coombs test is negative, then you need to induce the labor at 40 weeks. And when the status of cervix should be checked before induction of labor, actually you need to see whether cervix is even for the induction also you need to see like whether cervix got ripened or not. If it is not ripened, then which drugs you need to use. So that's why you need to see the cervix. So to check out the cervix, you use one scoring system that is called as Bishop score. So what is this Bishop score? Now we will start with this. They have 5 parameters mainly. Those 5 parameters are the dilatation of cervix, position of cervix. So these all 5 parameters we need to see and we should score them. Okay, you need to score first the dilation of cervix. How much the cervix is dilation? What is the position of cervix? What is the effacement of cervix? So 4, almost like 4 are related to cervix. How much the cervix got dilated? What is the position of cervix? What is the effacement of cervix? And what is the consistency of cervix? And another one is related to station of fetal head. So these 5 parameters are very important in Bishop score. So what is modified Bishop score? In modified Bishop score, instead of effacement of cervix, you will add another parameter, that is the length of the cervix is checked instead of effacement of cervix. So coming to position of cervix, let us see what are the scorings. So here, if the cervix is posteriorly located, then the score is 0. If the cervix is in the mid position, the score is 1. If the cervix is in the anterior position, the score is 2, because anterior position is favorable. So 2 is the highest score in the case of position of cervix. Position, okay. If cervix is posterior, it's posterior, so 0. In mid, somewhat better, 1. Anterior, very nice, so 2. Okay, so it is favorable. Coming to consistency. So consistency, if you see, if the cervix is firm, then the score is 0, means it is not ripened. If medium, okay, it's medium, so 1. If soft, it is 2. So cervix should be soft, means it has got ripened, so 2 is the score. So in the case of consistency, and if you see the position, the maximum score of Bishop score is here 2. That is in the case of anterior position you give 2, and in the case of soft consistency for cervix you give 2. This is the highest score. Now coming to, in position of cervix and consistency, the maximum score is 2. Now coming to the dilation of cervix. So dilation of cervix is the most important parameter, because you know dilation is the one which of course leads to labor, right? So if the cervix is closed, you can give completely 0 score, right? If the cervix is like 1 to 2 centimeter dilated, you give score of 1. Like remember 1 to 2, so 1. Next 3 to 4, 2. More than or equal to 5, the score is 3. So here the highest score is 3. In the case of dilation, the highest score is 3. Okay. So when it is closed, of course it is 0. When it is 1 to 2, 1. When it is 3 to 4, 2. When it is greater than 5, 3. So now coming to effacement of cervix. So already we discussed what is effacement, right? So effacement of cervix, if it is 30%, then the score is 0. If 40 to 50%, the score is 1. If 60 to 70%, the score is 2. If greater than or equal to 80%, the score is 3. So in the case of effacement and dilation of cervix, the highest score is 3. In the case of position and consistency of the cervix, the highest score is 2. So the scores are very important to remember. Okay. Now coming to station of fetal head. So station of fetal head is a relationship of leading point of fetal head with the ischial spine. Already we know this. So if the fetal head is above the level of ischial spine, it is negative station. If it is below the level of ischial spine, then it is positive station. So below the level of ischial spine, then only you say the fetal head has got engaged with the mother, right? So if the below level of ischial spine, below the ischial spine, the score is 3. If it is at the level of ischial spine, score is also 2. Okay, if the head is at -2 station, the score is 1. If head is above that, then the score is 0. So what you need to see is, if the below the level of ischial spine, engagement has occurred. So if the below the level of ischial spine means it's positive, right? So all positives, you will get the score of 3. If at the level of ischial spine, score is 2. Like you can see, even for -1, the score is 2. But if the head is at -2 station, the score is 1. -2 station score is 1. If head is above that, then just give 0. Now coming to maximum Bishop score is 13. So if you take all these parameters, if you take the highest point of each parameter, for example in the position of cervix, the highest mark is 2. So 2 plus, You can take care in the case of dilation of cervix, the highest score is 3. And in the case of consistency, it's 2. So position of cervix 2 plus consistency 4. So 4 plus dilation 3, 4, 5, 6, 7. 7 plus effacement 3, 8, 9, 10. And station highest score is 3. Right. So on total, if you see the total score of Bishop score is 13. So in this 13, if you do score for a particular person, if it is more than or equal to 9, then you say it is a success of induction labor. But if the score is less than or equal to 5, then you say it's a poor score, that the ripening of cervix should be done. Okay. So like this, this is how we define the Bishop score. Now coming to modified Bishop score. In modified Bishop score, we have another parameter, that is the length. Here we take the length of the cervix, right? So if the length of the cervix is greater than 4 centimeters, then you say the score is 0. And if the length of the cervix is between 2 to 4, you will say the score is 1. And if the length is between 1 to 2, your score is 2. If less than 1, the score is higher, 3. So this is about the length of cervix. Now coming to Bishop score, it is most common as effacement of cervix can be measured clinically. So effacement is more common when compared with this length, that is a modified Bishop score is less common when compared with normal Bishop score. The length of cervix can be measured only using the USG, so the modified Bishop score is most accurate, but the modified one is most accurate. Okay, now coming to drugs which are used in induction of labor. So most common drugs which is used in induction are of course prostaglandin, that is the prostaglandin E1 and the prostaglandin E2, and the prostaglandin E1 which is most commonly used is the misoprost. Okay, and the dosage is 25 micrograms and it can be used 4 hourly once. And the maximum number of doses which you can give is 6 doses. So next coming to PGE2, the most commonly used PGE2 is dinoprostone. So it is available as Cerviprem gel which is administered intracervically and the dosage is 0.5 milligrams and it can be given 6 hourly once and the maximum number of doses you can give is 4. So these drugs not only induce labor but also cause ripening of cervix simultaneously. So in patients with previous history of cesarean section, prostaglandin cannot be used. So already patient has gone cesarean section in the past, then you can't give prostaglandin to this patient. But it is not contraindicated. So one statement is the induction of labor is not contraindicated in the case of heart disease patient and also in pregnant women with the previous cesarean section. Now let us discuss about a new drug that is called as Cervidal. So Cervidal is a slow release formulation of dinoprostone. So even this Cervidal is also a dinoprostone but it is a slow release long formula. So it contains 10 milligrams of dinoprostone and it is placed especially in the posterior fornix, posterior vaginal fornix, and it remove it after 12 hours or before it if contraction arises. So actually it is a slow releasing drug and you can remove it when the contraction starts. So next coming to another drug that is mifepristone. Mifepristone or also called RU486. So it is actually an antiprogesterone and the dosage is 200 milligrams per vaginally. And next coming to oxytocin. Of course oxytocin is used both for induction and also augmentation of labor. Now coming to the mechanical methods of induction. So coming to the mechanical methods, you have Foley's induction. So Foley's induction is a catheter is inserted in vagina and the bulb is filled and pulled down till it reaches the internal os. So it is also called as transcervical balloon catheter. So it is like a balloon which you fill the water in it and you send till the internal os and open it by this help. So extra normal saline can also be pushed into the catheter and it enters into extra amniotic space. This is called as extra amniotic saline infusion. So best method for induction of labor in patients with previous cesarean section. So if patient have already previous history of cesarean section, then the best method is transcervical balloon catheter. So what is stripping of membrane? Stripping of membrane is an OPD procedure It is done during per vaginal examination. Actually, you put one finger and you will sweep and stretch the membrane, so it will release the PGE2, or you can say prostaglandins. And also you have hygroscopic dilators, but it is mainly used for abortion when compared with induction of labor. So in what cases the induction of labor is contraindicated? Now let us see that positions. Contraindication of induction of labor in the case of severe CPD, in the case of contracted pelvis, in the case of transverse lie, bro presentation, face presentation, especially mento-posterior presentation. In the case of fetal distress like non-assuring fetal heart rate, placenta previa, classical cesarean section, previous 3 LCCS and previous hysterectomy, previous myomectomy, active genital herpes virus, all these infections, all these are contraindicated. Now coming to drugs which are used for augmentation. So we have discussed about induction, now about augmentation. Augmentation is acceleration of labor. So to accelerate, of course, you will give oxytocin, and along with that you will do artificial rupture of membranes. In short, it is called as arm, and it is mainly done by scissors called as Kocher's forceps. It is having one tooth on one side and two tooths on other side with the presence of serrations. So we have got a new drugs like amnicots. Amnicots are small finger gloves which pointed tip, so you can pierce the membranes, and that will lead to augmentation of labor. Now coming to advantages. So prostaglandins, especially PGE2 is released, increases contraction. So PGE2 mainly leads to more contractions. And the color of amniotic fluid is checked for finding fetal distress. So if the color of amniotic fluid is green color, then you can say it is a fetal distress. So green color, fetal distress. And decreased bleeding in placental abruption, contraction begins, thus decreased bleeding. So what is the risk for artificial rupture of membrane? If the head is freely floating, then there is a risk. Harm can lead to cord prolapse and infections, trauma to the fetal head. So what are contraindications? Free floating head, HIV positive mother, active genital herpes infection in mother, intrauterine death of fetus. In all this case, there is contraindication. Coming to polyhydramnios. In polyhydramnios, if you do rupture of membranes, then entire amniotic fluid may come out, leading to sudden shrinkage of uterus, leading to abruptio placenta. So if sometimes in the polyhydramnios, if suddenly all amniotic fluid comes, then it will lead to abruptio placenta, that even the placenta may fall suddenly. So instead of artificial rupture of membrane, here we will do a controlled rupture of membrane. So controlled rupture of membrane means you will put only a small hole in the membrane. So because of that, only some fluid will be coming, trickling. There will be only trickling of amniotic fluid, but not sudden loss. So there will be no abruptio placenta in this case. Even though you try to do this controlled rupture, sometimes as this polyhydramnios amniotic bag is very much filled with fluid, even you try to do small hole, it will lead to lot of fluid loss. So in that case, you need to put a tissue or pads under the vulva of the female, and you need to slowly release the amniotic fluid to prevent the sudden loss of placenta or abruptio placenta in polyhydramnios female, in the case of even controlled rupture of membrane. So by this we completed induction of labor. Next we'll start with malpresentations.